Good morning, everyone. We're just a bit late because of the floor session that ran a bit late, so we're going to get moving. A quorum is present. I'm calling to order this hearing of the House Health, Finance, and Policy Committee. And the first item on the agenda is approval of minutes. And we have 3 sets of minutes, April 4th, April 24th, and December 1st. And I know everyone's been studying those minutes. And does anyone feel comfortable making a motion to, well, actually, why don't you all take just 30 seconds to look at them? And of course, the thing I always look for when I'm in your position is my name in the right place, right? Was I here or not here? So please do that.
Madam Chair, I did look over the April 4th and would like to move those.
Okay, Representative Quam, can we just move them all at once? Let's take a moment and look at all 3 of them, and if you would make the motion to approve all of them if you don't see errors and if no one sees errors.
Madam Chair, I can move to approve the minutes of the meetings on Thursday, February 15th, April 4th, and...
Well, Representative Smith, there's kind of a motion on the table here, so...
Oh, I'm sorry.
Sorry, Representative Quam?
Thank you, Madam Chair. I would amend that the December 1 doesn't show. I believe we had a roll call vote that isn't represented in the minutes.
Okay, thank you. Oh, Representative Quam, Ms. Niederhofer says that didn't happen on December 1. That was an informational hearing. Yeah, that wouldn't have been December 1. That was the date we had the informational hearing on managed care organizations.
Okay, so it wasn't the one, Madam Chair.
That day.
It wasn't the one that we voted and moved on the first day of. Okay,
Correct.
thank you.
So Representative...
Then I would not amend and would move to approve the 3 sets of minutes.
All right, thank you, Representative Quam. So Representative Quam's moving approval of the minutes of April 4th, April 24th, and December 1st of 2023. Any other discussion to these minutes? Seeing none, all in favor, please say aye. Aye. Any opposed? Motion prevails. The minutes are approved. And thank you, Representative Quam. I'm sorry, I should have said that the most recent minutes are not in this packet. They're still being prepared, so I'm sorry for that confusion. Okay, so first bill on the agenda then is House File 3578, Representative Bahner. And she is at the table. And Representative Bahner, would you like to move your bill? And I understand it's going to Commerce.
That is correct, Madam Chair. I would like to move House File 3578 before the committee, and it will be going to Commerce next.
All right, so House File 3578 is recommended to be re-referred to the Commerce Committee. So go ahead, Representative Bahner, to your bill. Oh, and Representative Bahner, you have an author's amendment, I understand.
I do, Madam Chair. I would like to move the A2-1 amendment to get the bill in the shape I would like it.
All right, so moving the A2-1 amendment that is in your packets, just to get this in the order in which the author would like to have it discussed. All those in favor, please say aye. 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 Opposed? Motion prevails. So the bill is in the preferred order, and go ahead and explain your bill as amended.
Okay. Thank you, Madam Chair and members. So prior authorization is not a new issue, and I suspect everyone in this room has experienced the frustration of prior authorization. The process used by this is the process used by insurers and health plans was originally intended to review care that may be expensive, experimental, or may have health and safety concerns before a patient may receive care. Health plans argue it's needed to ensure care is appropriate and cost-effective. Patients and doctors will tell you it interferes with the doctor-patient relationship, the ability to deliver preventative care, creates unnecessary barriers, delays care, leading to adverse patient outcomes and harm, all while creating administrative burden and increased costs. In 2020, we passed a prior auth reform bill, considered one of the strongest in the nation. The bill focused on process, reduced decision-making times, required adverse decisions be made by physicians of the same or similar specialty as the ordering physician, and required health plans to publicly post data on the use of prior auth on their websites to improve transparency. These reforms have been helpful. However, we've heard from practicing physicians the number of events requiring prior auth have increased, while patients continue to experience significant barriers to care. National data shows that physicians complete an average of 41 prior authorizations per week, spending 13 hours a week on approval requests, taking physicians and clinicians away from caring for patients, which directly impacts patient care. To that end, 94% of physicians report delays in care, 80% report patients have abandoned treatment, and 33% report adverse outcomes for patients, including 19% reporting life-threatening events. It's clear we have not met the intent of the 2020 bill, nor the original goals of prior authorization to deliver better care and increase safety at reduced costs. For these reasons, clarifications are in order. The bill has three main goals. It prohibits the use of prior auth for preventative and critical services that should not have barriers to care. It requires an annual report to the Commerce Department outlining how often prior auth is used, the approval and denial rates for care, and it directs the Commissioner of Commerce to work with stakeholders to develop a system that will allow providers that receiving the highest rates of approval to streamline the process and bypass approval via a gold card program, indicating their status as a trusted provider with an excellent track record of care. So let's dive a little deeper briefly from a high level. For 20 years, Minnesota law has prohibited prior auth for emergency services based on widespread agreement that patients should not have barriers to life-saving care. The bill expands preventative care and additional services where barriers to care may lead to severe or life-threatening patient outcomes. Just to give you a quick sample, this includes the use of generic drugs or biosimilars approved by the ADA. It also includes those recommended by the U.S. Preventative Services Task Force for preventative medicine based on practices to meet the goals of good health, harm reduction, and cost. It also covers things like medication to treat substance use disorder, including Suboxone, outpatient mental health and substance use disorder treatment, cancer treatment consistent with the National Comprehensive Cancer Network guidelines, such as chemotherapy, radiation, gene therapy, and bone marrow transplants. And lastly, it also covers pediatric hospice services and treatment for neonatal addiction. So let's be clear, the barriers to care for these services are dangerous. And according to health plans' own websites, they're usually approved between 80 to 95% of the time, meaning they're almost always approved. In addition, the bill prohibits the use of prior auth for providers already accepting risk through value-based contracts. For patients with chronic diseases for which treatment rarely changes, like diabetes, it prohibits insurers from requiring the patient to seek approval more than once for the same treatment. Because services are covered, it should add no cost to the insurer. However, it would greatly reduce the cost to physicians, clinics, hospitals, and patients. The second major goal of the bill requires the insurer to create an annual report to the Commerce Department, providing policymakers with critical data to make sure it's being used appropriately. It clarifies the intent of the 2020 law to increase public transparency, standardizing data to an apples-to-apples comparison, and ensures the posted data on the website can be easily found. It also directs the Commissioner of Commerce to use the data to make recommendations to the Legislature on how to simplify health insurance prior auth standards and processes to improve healthcare access, reduce delays in care, reduce administrative burden on healthcare providers, and maximize quality. And finally, the final goal is a gold card program. Many states have passed similar programs in which providers who have high approval ratings do not have to use the prior auth for those services. And this version of the program exempt providers whose approval rates are in the 70th percentile or better, focusing on prior auth on outliers through rulemaking. And with that, I do have, I think we have one amendment, and then I can move to testifiers.
Right. Representative Bahner, the amendment, you have an amendment, that you're bringing an amendment, or there's an amendment?
No, there's an amendment.
All right.
To bring to the-
All right. Well, we will take that up later after the testimony.
okay.
I have several testifiers here listed that are part of your presentation, I understand. So Laurel Rees. Welcome to the committee.
Thank you, Madam Chair and our committee. My name is Laurel Rees. I'm a family physician here in St. Paul. I practice on Rice Street, just up the street here, and I'm the current president of the Minnesota Medical Association. The Minnesota Medical Association represents 10,000 member physicians and physicians in training, and also the Minnesota AFP. And we are speaking today in support of House File 3578.
And if I could just interrupt, you used an acronym that, please tell us what that is.
Minnesota Academy of Family Physicians.
Thank you.
Death of 1,000 cuts used to be a form of torture. Now it is a way of life with prior authorization. Prior authorization, when recommended medical care must be pre-approved by health plans, is a leading dissatisfier for both patients, that's us, and healthcare teams and physicians alike. Originally a tool to control costs for niche and super expensive medications, the process has expanded massively and now includes routine care, preventative care, generic medications. The results are delays in care and use of already extremely stretched thin healthcare resources. Let me give you an example. So this is from my practice in this neighborhood. A patient went to refill her insulin. She was running out of insulin that day, so she called her pharmacy. She's been well controlled on a high dose of insulin for a long time. Same medication, she just called to refill it. The pharmacy let her know that her insulin was requiring prior authorization now. She's been on this medication. So the pharmacy sent us a message to let us know. And because she was running out of insulin that day, her daughter also called our clinic and left a message for us saying, my mom needs this insulin today. So I got the message at my clinic and I said, absolutely, she needs this medication. So I immediately sent it to our team of professionals that we hire specifically for the purpose of doing our prior authorizations, and they did the paperwork immediately. And we're told that they would get a response within 72 hours. Now, in 72 hours, this lady would be in the hospital if she didn't have her insulin. So I sent this on to our clinic pharmacist, who was familiar with the urgent need insulin availability in Minnesota. So he sent the message on to our social worker, who helped the patient's daughter fill out the paperwork so that she could get this insulin covered today. And then her daughter drove into the clinic to get this paperwork to take to the pharmacy so that they could afford to get her insulin today. And this is a success story. Our patient got her insulin that day. She had no negative outcomes. But this is an everyday story in our practices. And as you mentioned, the average physician in Minnesota is having 41 prior authorizations per week. So this is not an everyday story. This is a multiple times a day story. This is how we're spending our time and our resources. In this case, she would have had one phone call to refill her insulin if it had not been prior authorization, because it was a stable chronic medicine. She was well controlled. All she should have had to do was call to get that refilled. Instead, it took 8 people, 4 phone calls, and a trip from her daughter into the clinic, so she came in after work to get this so she could get her medicine for her mom. And so it's taking a lot of resources to get this work done. And it was a potentially unsafe situation. If her daughter hadn't advocated for her, if our team hadn't responded to messages right away, she would have been in the hospital, because that would be the only way to get her insulin. The HF 3578 seeks to relieve this burden on both patients and our healthcare teams with limitations on prior authorization for recommended care. care that's recommended for patients, including generic medications, preventative care, cancer care, things that we really want, substance use treatment. These are the things that we want. And it also helps to increase transparency so we can better understand the effects of prior authorization on Minnesotans. So we ask for your support today for HF 3578. Thank you.
Thank you for your testimony. Next, we have Maureen Alderman. Welcome to the committee.
Hello. Excuse me, I'm getting over a cold. My name is Maureen Alderman. I'm a resident of Victoria, Minnesota, and I am a patient advocate serving on the Minnesota Rare Disease Advisory Council. I work in quality and food safety in my daytime, but more importantly, I am a mother of two incredible children, Cameron and Caroline. I'm here to speak in support of HF 3578, testifying on my own behalf. Caroline was born in November 2020, and thanks to the newborn screening, discovered to have a very rare health condition just 2 days after birth. This is Caroline today, at 3 years old. Caroline has a condition known as arginocincylic aciduria, which is the hardest thing I will say today, ASA for short, a type of urea cycle disorder. This means that her body cannot fully digest protein, and instead it creates ammonia, which can be lethal to your body. Thankfully, the newborn screening saved her life, and the medical care we have received since has only continued to increase her quality of life. When Caroline was born, we were given a very bleak outlook for her long-term life. Holding my 6-pound baby in my arms in the NICU, my husband and I were told she was the 5th case with her condition they had ever seen at Children's Minneapolis. Not a single nurse that we saw had ever heard of her condition, nor did they know how to help us move forward. ASA is a condition impacting 1 in 70,000 people. Something like Down syndrome is 1 in 700 for comparison. Learning about the rare disease world was something that we were thrown into headfirst, ready or not. What we discovered was that there are specialists for these rare conditions, but they're spread across the country. By the grace of God, we found a world-renowned specialist right at our doorstep at the University of Minnesota. Under the care of her team at the U, Caroline's development has far exceeded anything we could have ever imagined. This is due to the outstanding care team we have that has been so well informed to keep Caroline on the right path while she manages a very complex diet and medication routine. In those early NICU days, we were told that Caroline's health would have an immediate impact on her IQ and overall development. That's something no parent wants to ever hear about their baby. However, Caroline's incredible doctors, paired with the proper diet and medication, has allowed her to have less frequent doctor visits, lab draws, and more freedom to be a happy, healthy, and thriving toddler. Caroline will forever be on 3 prescription medications throughout her life, as her condition is chronic. She will always have a special prescription formula that provides the protein that she can digest without getting sick, a prescription amino acid supplement, and a revolutionary drug called Ravicti, which is considered an ammonia blocker, so she doesn't have high ammonia levels. This medication maintains Caroline's ammonia level if she were ever go into a crisis, as they call it. Ravicti is unfortunately only available at 2 pharmacies in the country. There's no generic or other medication that can replace it, so it is new to, and is also new to the market. Because Ravicti is expensive and rare, our insurance annually would love to supplement it for something else. So at the end of June, we have a calendar reminder that goes off on my husband and my calendar that says prior auth for Ravicti, because on July 1st, we know we will receive a letter that says our coverage expires and we are required to go through the extensive prior authorization process again. Now, thankfully, we have an incredible care team that knows how to fight this battle. Our doctor knows what to write in the letter to the insurance company to explain the criticality this medication plays in their patients' lives so that there's no delay in Caroline receiving this critical medication, a delay that could be devastating to her function. But unfortunately, that is not the case for many rare disease families. Since there is no margin of error, any disruption in having a competent care provider could mean delayed access. Additionally, we have been very fortunate to only wait on pins and needles for a few weeks to hear we have been cleared to continue to get the medication. But in the case that doesn't happen, what happens to our daughter's health? Everywhere we go with Caroline, we carry what's called an emergency letter, because if she gets sick and her ammonia gets high, it isn't weeks that we could see impacts. It is hours, and doctors have told us it truly could be minutes. So without her medication, instead of playing in our yard with her big brother, she could be in a coma in the hospital. To be honest with you today, this isn't something I even let my mind normally go to, because no parent should have to think about what if you cannot access the drug you know is saving your child's life. This shouldn't be a question, but it is for many chronically ill people. The stress endured knowing that the medications are out there to keep you and your loved ones healthy, but insurance or paperwork may be keeping you from it, is not the way we should be operating. So as I sit here, knowing my 2 healthy, beautiful children can't wait for me to get home so we can go to skating lessons as a family, I hope you will think of Caroline and the other rare disease families as you consider passing this bill. Well, we want to make memories together instead of on the phone with insurance companies, or even worse, sitting bedside in a hospital together.
Thank you for your testimony. Nicole Hilges. Welcome to the committee.
Thank you, Chair Liebling and committee members. My name is Nicole Hilgis, and I'm the manager of prior authorizations at Children's Minnesota. I appreciate you having me here to express our support for House File 3578, which makes changes to prior authorization requirements that would allow us to better serve our patients and families. Children's Minnesota is the state's largest pediatric health care system, seeing more than 160,000 kids annually. In 2023, the 30 members of our prior authorization team worked to complete over 81,000 requests for nearly 58,000 individual patients. These were children suffering from cancer, heart conditions, asthma, and other diseases that need prior authorization or PA approvals before our clinicians could treat them with the appropriate medications and healthcare services. Today, I want to share the impact this had on one of our patients and families. James, whose name has been changed to protect our patient privacy, is an 11-year-old boy who has been diagnosed with leukemia and is insured through Medicaid. 3 months ago, my team submitted a PA request for a drug to treat James's cancer and learned that it was denied because the drug we requested, though it is the standard of care for this illness, was not the preferred drug for Medicaid. Medicaid instead recommended that we try 2 other drugs not approved for a patient James's age before using the drug they denied. The drug suggested did not follow the recommended standards of care outlined by the National Comprehensive Cancer Network guidelines and are not drugs that we would use to treat a patient like James. My team and I are still working to appeal this denial on behalf of James's family so they can focus on their child's care without additional stress. James' story is not unique. In another case, a request for a liquid form of cancer medication for a patient was denied and a tablet was suggested instead. The patient was 2 months old. A tablet could not be dosed or administered appropriately for a child of that age and size. Getting PA approvals for liquid medications that can be appropriately dosed for young children has also been a challenge for patients in hospice and also those experiencing neonatal withdrawal. Our prior authorization team and members of our care team serving these patients work tirelessly on cases like these, spending hours working on individual PA requests while also trying to protect patients and families from additional worries and concerns. After going back and forth with denials and appeals on these cases, 95% of these requests eventually do get approved. But too often, the time it takes to complete the process threatens to delay patient care, leaving families to make the difficult decision on whether to move forward with their child's treatment without knowing it will be covered by their insurance. These are not things a family should have to worry about while their child is fighting a life-threatening illness. We can do better for our children and families living in our state, and House File 3578 gives us the opportunity. Thank you, Representative Bahner, for your leadership on this bill, and thank you, committee members, for having me.
Thank you for your testimony.
Thank you.
Okay, I think that completes your list, right, Representative Bonner? Okay.
That's correct,
so-
Madam Chair.
So next we have Dan Andreessen. Welcome to the committee. Please go ahead.
Thank you, Madam Chair. Members of the committee, my name is Dan Andreessen with the Minnesota Council of Health Plans, the trade association for Minnesota's nonprofit insurers, which include Blue Cross Blue Shield of Minnesota, Health Partners, Medica, Sanford Health, and UCare. We want this process to work as well as possible. And if the issues that you've heard today is involving one of our member plans, we want to know so we can fix the problem. We've always told proponents that we want to find solutions to specific problems so patients are not put in the middle. But to broadly eliminate the use of PA is the wrong approach to solve these problems. And it's going to reduce patient safety and increase the amount patients pay for care. We have many questions on how the provisions in the bill will work and how it's going to interact with incoming federal regulations. PA is a real-time double check of healthcare services and treatments on behalf of our enrollees. PA criteria is established using clinical practice guidelines, peer-reviewed evidence-based studies, and adherence to state, federal laws, rules, and regulations. We use PA to ensure patient safety and to check if the care being delivered is appropriate and won't cause harm. And I know some will bristle at this, but mistakes can happen and things can get missed. And we should all work together to make sure we catch these mistakes before they happen. PA is also about making sure care is not unnecessary, and we're promoting options which are a lower cost to patients so they're not overpaying for their care. We're all worried about healthcare spending, out-of-pocket costs, and the growing problem with medical debt. As a patient, you don't have the line of sight to know if the treatment that's being prescribed to you is the best financial option being offered. Health plans are able to provide that real-time scrutiny of the care being delivered. Health plans try to be targeted with their use of PA, and it's not used for all healthcare services. And as Representative Bahner mentioned, it's prohibited for emergency services. We focus it on emergency and services and treatments which have the potential to cause significant patient harm, have a high cost, have lower cost alternatives, or for services which plans see a track record of inappropriate use or fraudulent use of care. In fact, it's used less frequently than you may think. For our health plans, the number of PAs, when you compare that to the total number of claims that we process, over 98% of those claims do not involve PA. Now, that's not to say that prior authorization is not used, and if you're a provider who cares for patients with complicated conditions or prescribes treatments that may cause harm, are expensive, you may be submitting more PAs than your peers because of the patients that you're treating. We know patients have concerns over PA, and as has been mentioned, the legislature responded to those concerns in 2020, establishing requirements on the development and use of PA by health plans and created timelines for when PA's reviews must be completed to address the concerns about delays of care. Right now, state law requires that all PAs be done within 5 business days. Any expedited review at the request of the provider must be completed within 48 hours. Now, these requirements only apply to the fully insured market, and they weren't applied to the Medicaid or Minnesota care programs, and also the law doesn't apply to the employer market. Now, we've heard concerns that PA delays care. However, we're confused on how these timelines, since these timelines are now in place, and wonder if these concerns are coming from markets that are not being covered by this law. As the bill moves forward, we're committing to meeting with Representative Bahner and bill proponents on the language in the bill. As I mentioned at the beginning of my testimony, we do have several questions around specific provisions. First of all, just a week ago, CMS published a very large federal rule on PA and interoperability. This rule establishes its own PA timelines, requires creation of a PA automation system, patient and provider portals, and new health plan reporting on PA. Our plans are still digesting this 822-page rule, and we think that there might be some contradictions with this bill. Section 5 requires plans to create an automated PA process, which we're all for moving this process along, but we're concerned whether providers are going to use it. Given the lack of provider compliance with the state law when it comes to requiring electronic prior authorization for prescription drugs, what assurance do we have that providers will use this system before we build it? Section 6 lists several conditions exempting from PA. We're seeking some more information on the specific issues that are happening in the fully insured market for our members, and how the current timelines are not solving the situation when it comes to delayed care. Section 7 regarding chronic conditions, the way that it's defined currently in the bill is very broad. It includes any condition that lasts for more than 1 year and has ongoing treatment. So this could include something like cancer or multiple sclerosis, but it could also be something like high blood pressure, obesity, back pain, sleep apnea. It's almost anything. Section 6 references exemption of value-based arrangements, which we're all for using, but it's not clear on how the language is going to impact the current contracts that are in place, and we certainly don't want to create any roadblocks to continue using these arrangements in the future. And then Section 8 on the Gold Card program, we're still trying to figure out how it's working. It sounds like what they're looking to do is essentially it's your top 30 performers. It's not necessarily a 70% grade, and correct me if I'm wrong. But essentially, if you're a health plan that has 100 providers in your network, the top 30 gets the Gold Card. And so we don't really know in that 30 percentile what's the performance. You know, at the top it might be high, but once you get down to closer to 30, we don't know what that will be. But we also have questions about how it would apply to individuals and groups. Would a group be an entire medical system? And then the appeals process. But you know, at this time, we're opposed to the bill, but happy to continue talking with Representative Bahner and proponents as this moves forward. Thank you.
Okay, thank you. Michelle Crimmins. Then we've got Bentley Graves and Michelle Benson, if you could kind of be ready to come up when your time comes here. Welcome to the committee.
Thank you. Good afternoon, Chair Liebling and members of the committee. My name is Michelle Crimmins. I'm a registered lobbyist representing Prime Therapeutics, a pharmacy benefit manager that is headquartered in Eagan, Minnesota. Prior authorization use for the health benefit and the drug benefits are very different. For example, a knee replacement surgery is performed once. A drug to treat a chronic illness is taken for life and requires ongoing monitoring. Because of these differences, it's important to note that my testimony today solely discusses the impact of HF 3578 on the use of prior authorization for prescription drugs. Prior authorization requirements are set on prescription drugs that should be used only for certain health conditions, have dangerous side effects, are harmful when combined with other drugs, may be misused or abused, or if there are equally effective drugs available at a much more affordable cost. For example, many drugs to treat breast cancer require genetic testing to confirm that the prescribed therapy will benefit the patient. In that instance, a prior authorization would ensure that the genetic testing was completed and the drug would be of benefit. Section 8, Subdivision 1 of HF 3578 sets a prior authorization exemption process, typically referred to as gold carding. This exemption process creates a percentage-based threshold of which, once met, exempts a provider or provider group from prior authorization requirements. Prior authorization requirements ask for documentation showing that clinically appropriate and industry standards were met to ensure that the drug is safe and will be effective for the patient. It does not make sense to remove a check and balance process that ensures patient safety and drug affordability. This isn't the first time that we've discussed the value of prior authorization programs. As mentioned several times over today, in 2020, Minnesota passed SF 3204 into law, and this bill set reasonable requirements for use of prior authorization, such as the annual posting of prior authorization data on a plan's website, a limit on prior authorization data request requirements, a required health plan change notifications, a requirement for any adverse determinations to be made by a licensed physician in the same area of practice as the prescribing physician. We think that these requirements were reasonable. Section 12 of HF 3578 asks the Commissioner to issue a report analyzing the use of the prior authorization in healthcare. The report is to analyze the effect of utilization management tools on patient access, administrative burden, and system cost. If additional information and additional research is needed on the use of prior authorization, our recommendation is that we move forward with that report. We find the problems with the process, and then we move forward with discussions on how to better improve the process for everyone involved in the healthcare system. For these reasons, I oppose this bill. Thank you.
Thank you. Bentley Graves. Welcome to the committee.
Thank you, Madam Chair and members. My name is Bentley Graves. I'm with the Minnesota Chamber of Commerce. We're the state's largest business organization. We're a statewide trade association representing more than 6,000 employers across the state in every corner of the state. in every industry of the state and every size of business in the state. And our members have as a chief concern in questions of health policy cost. 80% of our members who offer insurance do so through the fully insured market, which is the segment of the market that the legislature regulates and oversees. And those cost considerations come up, daily for our members and their employees. In particular, given the fact that the all-on healthcare spending by Minnesota families ranks third highest in the country, according to researchers at SHADAC at the University of Minnesota. So this is a real and present concern for our members, and is what motivates us in our engagement in these questions. So we have, as many here, been involved in these conversations around prior auth for a number of years, including back to 2020. And centering us in those conversations has been our effort to maintain prior auth's usefulness in ensuring quality and safety in care, but also as a mechanism for cost control. But also, we want to look for opportunities to bring prior auth in line with today's technology and healthcare ecosystem. And we think there are actually pieces of this bill that could do that well and move us along down that path. In particular, we'd like to draw the attention of the committee to Section 5, which, as discussed earlier, lays out a new automated process for prior authorization. And Section, I think with the amendment, it'll change section designations, but Section 7, subdivision 6, regarding to value-based care arrangements that tie payments to quality, that reward efficiency and effectiveness, and that share risk. Those two mechanisms, we think, will go a long way in solving this problem. And frankly, leaning into value-based payments, we think, would go a long way to solving other issues in the healthcare ecosystem as well. But ultimately, as we've talked to stakeholders involved in this conversation, the issues of delay in care, increased administrative costs, and hassle for all, including lending itself to physician burnout, are the reasons why we have bills like this in front of the legislature. And our view is that these two components of the bill in particular would significantly move us down that path of addressing those issues. But I also want to speak to a couple other pieces of the bill. Section 6 regarding a new list of procedures that would be exempted. Section 8 requiring what I guess is referred to as the gold carding at 70% and above. Our policy proposals and provisions that the legislature could pull the lever on. But we would note, as I guess was just mentioned, sections 10 and 12 do require new submission of data to the Department of Commerce, as well as a responsibility for the department to analyze that data and make recommendations to the legislature, and I'll quote here, on how to simplify health insurance prior authorization standards and processes to improve healthcare access, reduce delays in care, reduce the administrative burden on healthcare providers, and maximize quality of care. Those are great things to know. And we believe that the data that would be collected as part of this would help the department identify some of those opportunities, which may well align with exempting illicit services or setting up a gold carding program. But whether that's a gold carding program at 70% or 65% or 95%, I think would be well informed by the analysis of that data and the recommendations of the department. So we think that there are, again, opportunities potentially within that space of the bill, but would certainly urge a review and analysis and collection of the data and recommendations to inform that. And then finally, I'd just say there is the beginning of the bill, Section 2, we're pleased to see would apply this equally to public programs, both for kind of an equity standpoint, but also from a standpoint of cost. Again, bringing this back to where I started. We don't often have a lot of tools to measure the cost implications of changes in policy made at the legislature with regard to health insurance policy in the fully insured market. But a proposal like this that would apply equally to both will at least give us some sense through a fiscal loading process of what the state thinks any cost implications of a change like this might be. We think that's very helpful and would further obviously inform this conversation in our involvement in it. But I want to thank Representative Bahner for taking the time to sit down with me yesterday, and the proponents of this as well for the conversation we had. We want to be a productive part of this conversation as we were in 2020 and look forward to that going forward. Thank you, Madam Chair and members.
All right, thank you for your testimony. Michelle Benson. Welcome, former Senator Benson. And so is this the first time you've testified now since you've been
Yes,
back?
Madam Chair.
Okay, well, we should be
Thank you, Madam Chair.
popping the champagne or something.
No, do not. Let's
Welcome.
not pop champagne too early, Madam Chair. Thank you, Madam Chair, committee members, and Representative, for your work on House File 3578. I'm Michelle Benson. I represent the Health Plan Partnership of Minnesota, and I thank you for the opportunity to address our concerns as House File 3578 moves forward. The goal of streamlining and simplification is laudable, and we share those goals. It increases access, improves quality, and provides affordable care to Minnesotans. We will work to solve problems. I heard the stories today and know that there's work that can be done. Our primary concerns with House File 3578, as it was presented today, relate to compatibility with the emergent changes at the federal level, and broad exemption with prior authorization, including gold carding. As the committee is aware, CMS is promulgating rules around interoperability of electronic health information and the streamlining of prior authorization. These rules will be in effect in 2026. The stated goal of the CMS rules is to reduce the burden for patients, providers, and payers, ultimately reducing cost and increasing access. We applaud these efforts, and we hope that the committee will keep those in mind. Minnesota policy should follow federal rules as they move forward, and then make prudent policy changes to align with the standards with our shared goals of access and quality. Additional concerns relate to blanket prior authorization and gold carding. Prior authorization is intended to focus on patient safety and value in patient care. A therapy or treatment that is new or more expensive doesn't necessarily mean it delivers better outcomes or the individual need or meets the individual needs of the patient. Innovation continually brings new drugs, therapies, and procedures to patients, and more often, they're part of an individualized care model. Gene therapy is just one example of a highly individualized, rapidly evolving, and expensive way of treating patients. In a time of rapid change and patient-specific care, a blanket approach to PA exemptions could put patient safety at risk, raise costs, and not necessarily improve outcomes. Additionally, the 70% threshold for gold carding would be among the lowest standards in the country, likely raising costs and lowering quality, according to studies from the Liebling Group. Minnesota is known for having the highest quality standards for our care, and we believe a 70% standard is not reflective of the providers of our state. In conclusion, I want to thank you for listening to these concerns and the concerns of those before me. We ask that you monitor federal progress and stay in alignment for simplification and cost savings. Keep prior authorization focused on high-quality, value-based care in a rapidly evolving, individualized healthcare ecosystem. Thank you, Madam Chair and members. Representative, I hope to have the opportunity to meet with you and talk about more specific concerns and find a path forward for Minnesotans. Thank you.
All right, thank you for your testimony. Is there anyone else in the room who wants to testify for or against the bill? All right, not seeing anyone, we can take up the amendment. If there is an amendment in our packet, the A1. If anyone, is that Representative Nadeau? Did you want to offer that amendment, or someone else?
Oh, I'd like to do it, if that's all right, Madam Chair.
You have the floor.
Thank you so much. My amendment is fairly simple in what I think is a very confusing part of the bill. It's in Section 8. It's on line 5.24, and I disagree with Mr. Andreessen in his understanding of this section. I think that this section is actually theoretically 100% of providers could be eligible for a gold card under this provision. I don't know that it's, as long as they're above the 70th percentile in in prior authorizations, it appears to me that they would be eligible in perpetuity to having this gold card status. I'm not sure, and maybe the author can clarify if I'm wrong and show me in this language where I'm wrong. But my amendment, and I move that we change page 5, line 24. We delete 70th, and we insert 90th. And the reason for that is I would prefer that as we move forward with this bill, you know, we're using a higher standard. It's A- doctors rather than C+ doctors when it comes to prior authorizations. If we're going to make a mistake, which I'm not saying we are, I just want to make sure that we're starting at a high threshold, because these providers in this threshold are really never ever questioned again. And I've got a lot to say on the bill, but that's my amendment, Madam Chair.
All right. Representative Bahner.
Thank you for that. And I do want to start with, I really appreciate Representative Nadeau, and I think you often bring forward really thoughtful suggestions, constructive feedback, and I really appreciate that. And I almost wish we'd had a little time to chat beforehand. But I want to be very careful when we talk about this, and there's a lot of confusion about the percent versus percentile and what that means. And basically what we're talking about is we're talking about the top third of providers here. These are the folks who are the cream of the crop. Who are these providers? These are generally folks who are sort of specialists in their field. These are folks who have vast knowledge and experience in their field. And based on prior authorization in the past, have proven track records of actually knowing exactly what they're doing and getting those approvals. These are folks who, and keep in mind that most of the things in this bill, we want to be very clear that we have targeted are things where they are really obvious preventative things, which I think we would all agree can help bring down costs, which is a good thing, or they're very narrowly targeted items that are reasonable, that are common sense. And the vast majority of these also enjoy an 80 to 90% approval on the first request and 70% approval on appeal, which means that nearly every one of these gets approved, right? So what we're talking about is selecting the providers who are the specialists, who are that cream of the crop, who are consistently they have the receipts that they're doing it right. They have the receipts that they are, in fact, doing the right thing consistently, time after time after time. And so while I certainly think it is worthy of discussion about that percentile and would certainly be willing to work with you offline to see if that is the most appropriate, for today, I am going to politely decline, but I would like to commit to you that I would like to have an offline discussion about this and look at if this is the right path and if there is adjustments that should be required.
Representative Nadeau.
Thank you, Madam Chair. I'll talk about the whole bill later, but thank you. I still renew my motion.
Okay. And so a couple of other members put their names on the list, and I didn't know if that was to the bill or to the amendment. Probably to the bill. To the bill. Okay. So other discussion on the amendment. Representative Elkins and then Schumacher.
Yeah. Thank you, Madam Chair. Just real quick, I've also found this language really hard to interpret, so I would it probably needs some further wordsmithing to clarify it.
Okay. Representative Schumacher.
Thank you, Madam Chair. And that was kind of the same point I wanted to make, and just wanted to get a couple of definitions in this area since we were talking about this through the amendment too, and just wondering the difference between a provider and a group of providers and what constitutes a group of providers.
Representative Bahner.
I may phone a friend.
Okay. Welcome to the committee. Please state your name.
Madam Chair and members, Dave Renner with the Minnesota Medical Association. In the bill itself, there's not a definition. But what we were arguing, as Representative Bahner has said, is if somebody meets the top of the top, whether it's a one-person clinic or a five-person clinic, if they're all meeting it, then they would be able to be included as part of that gold card. But as I say, but again, a reminder, this is all going to the Commissioner of Commerce, who will work with stakeholders and try to develop recommendations and come back with some definitions about how we address those issues.
Representative Schumacher.
Thank you, Madam Chair. So my understanding then from what you just said is that it would be limited to the group and not like It couldn't be, the group couldn't be considered the association or of all statewide physicians. It has to be to a specific clinic, not even to the entire system of physicians, but just the clinic that they have. Is your intention with that?
Madam Chair and Representative Schumacher, yes, and maybe we could put a definition of group, but group, we didn't, is it an individual standalone clinic? Is it a part of a larger system? But the concept, yes, it would be a group of physicians who are working together, practicing together to provide care.
Okay, thank you, Madam Chair.
All right, Representative Carroll.
So just to follow up on that, thank you, Chair. Isn't that just a practice group, simply?
Mr. Renner.
Madam Chair and Representative, that's one potential, yes, but, and again, we may need to put a definition of what a group is, but sometimes a group can be, again, a standalone solo practitioner. Sometimes it can be a multi-specialty group, but that's the concept, yes, as a practice group. Sorry.
Representative Carroll.
Thank you. I would think that a group is more than one, so it wouldn't be a solo, right?
Mr. Renner.
Madam Chair, correct.
Thank you.
All right, seeing for no further discussion on the amendment, so all in favor of adoption of the A1 amendment, please say aye. Aye. All opposed? No. The motion does not prevail. The motion does not prevail. The amendment is not adopted. So we're back on the bill as amended. And Representative Quam.
Thank you, Madam Chair. And I'm not sure if it would be Ederson or Benson. I've got a question about a compromise or some type of thing that the health plans, if they would be interested in. And I'll start with the author in that about a decade ago there was a meeting in Rochester with medical and health plan people and executives. And in that meeting, it came up that in mental health, there were a few inexpensive first treatments that were tried, medications. But if it got past those, that the plan went ahead and did a pharmacogenomic test to see what would actually work for that individual. And then they picked out of the group of remaining what was the best one for that individual. For probably a decade, I've been trying to do things smarter, and that you said the gold card thing, they're very experienced. And part of that is they've picked up indicators when you use something outside of the predominant treatment. And pharmacogenomics looks at actual scientific data to choose what is the best medication out of the available. And I would hope the plans would support the addition to this bill that said that if a pharmacogenomic test is performed and that data indicates a medicine, that it would automatically get prior approval because science is saying for your specific individual genetics that you would do best with this medicine. And also, it would save money because I think it was Kentucky, the teachers union medical plan did a study, and they saw that when they had people with the testing, that they avoided ER visits, had shorter stays in the hospital when they were hospitalized, and the actual cost of medications decreased dramatically. So if we're worried about controlling the cost, and pre-authorization is part of the function that's been around, we should actually get up with a new science and say automatic pre-authorization if it's indicated by a pharmacogenomic test. And it's getting more and more mainstream, but I think that's a win-win, and I would have hoped that it was a key part of this bill.
Representative Bahner.
Well, thank you for that, Representative Quam. And, you know, obviously, I think some folks in this room may be well aware that Representative Quam and I have been working on this for some time now. This is an emerging science, and one of the beauties of that particular type of science is that sometimes today, and sometimes even we see that reflected in PA requirements, is that what we often do is we tell patients to try and fail things before we give them what we think will probably actually work. And the idea of this emerging science is to look at which treatments are most effective, particularly in different areas and based on different individuals, to be able to target a little bit better and to be able to skip over some of those steps. Because every time a patient tries and fails a medication, there could be contraindications, there can be side effects, and not to mention it wastes time and money. For patients, for health plans, for physicians, and for everyone all around. And it certainly doesn't improve care when we're just throwing spaghetti at the wall, right? So I think that there's very practical things there. We did not consider that for this bill, but I think that that is a really promising area of study, and I'm hoping that it will continue to emerge. I think you know how I feel about that, Representative Quam. And I would like to see, as those studies and that science continues to emerge, that it may be able to help us inform better decision-making skills, especially when we talk about prior authorization. So it's certainly something I'd love to explore in the future. We did not include it because I know the health plans will tell you that it is still emerging science, but I do think it's quite promising. So thank you for that suggestion.
Okay, thank you.
Madam Chair,
Briefly, Representative Kwong?
yes, Mayo Clinic, I grew up around there, I'm active, and I'm used to the cutting edge of medicine, which saves lives that wouldn't have been saved otherwise. And at some point, Minnesota should lead like we do with the Mayo Clinic.
All right, a little commercial break there. Representative Fisher.
Thank you, Madam Chair, and thank you, Representative Bahner, for bringing this bill forward. I think it's very important. Some things I'm looking at very favorably is taking a look at some of the data you're going to be collecting. And one of the things I want to kind of reference is we heard some people mention that CMS has come out with this new guideline that that people have to follow. And I want to kind of root us a little bit as where that came from, is that the Office of the Inspector General came out with a report in July of last year that took a look at what is happening in the Medicaid plans along with denials. And one of the things that they said very clearly as they were going through the report is that they felt that there was a problem with this, the lax oversight of states and the high rates of denial that was happening in the managed care organizations. To give you an idea of what the report found that denial rates were between 2% to as high as 41% of all claims for prior authorization being denied. 41%, I say, is extremely unacceptable. And the fact that as states, we've not been doing our oversight in those areas. And so that's where I'm looking forward, is making sure that we have some of those clear data coming back to us to make sure that we're making sure that those who are most at risk and are not always able to advocate for themselves are making sure they're getting their services. Because so often what we find is when people on our Medicaid programs, particularly that are relying on us as the safety network, are already in situations where they're not able to always advocate for themselves. And as a result, when something gets turned down, they don't have the capacity or the challenges always to be able to go forward and say, no, please resubmit. And some of the examples I've seen that have come to my office of people complaining to me over the years has been, in one instance, a gentleman had come in and had lost his leg. He had a temporary prosthetic that he was able to use and had asked for a permanent one. The prior authorization was denied because it was said it was not medically necessary, while at the same time the temporary prosthetic was causing further sores to develop on his leg and not heal. These are some of the problems that comes out in the system. Another instance where a person had gone to one of our hospitals, needed a procedure because they were at a high risk for a stroke. It needed a pre-authorization. Unfortunately, that pre-authorization took too long, and they ended up having to be admitted to another hospital for emergency procedure at much higher risk and almost died because they weren't able to get the services when they need. there are problems sometimes in the pre-authorization system, and there are some companies, we've got a lot of companies doing the right thing with pre-authorizations, but not all companies do. And this is why we need this kind of action out there to make sure that we're addressing these type of situations. I think that one of the things we have to realize is that our healthcare system has changed. We have more and more for-profit companies. And some of these, and the reason I raise this up is some of these for-profit companies, over 80% of their revenue is coming from providing managed care. And these are also some of the companies that have the highest denial rates. When we're talking about a 41% pre-authorization denial, this is the population that is impacted, a population that so often has disparities in healthcare. And this is why starting down this road is necessary, because we have a responsibility as a state to not only take care of making sure that we're doing things cost efficiently, but making sure that we're providing basic health care. And the Office of the Inspector General is saying that as states throughout the country, we are failing on this, and I think this is one of the steps to move us in that direction. So I will say thank you, and I'm looking forward to the data collection to make sure that things are being done properly, and if they aren't, we know where we need to focus in this state.
All right, thank you, Representative Fisher. So final comment, Representative Nadeau, and then we will move to a vote.
Thank you, Madam Chair. All right, and so now I get to talk to the big bill. And thank you, Representative Bahner. This is, these are these complicated issues that I like to think about. I like to work on. And I think Representative Fisher kind of summed up something really important. Is a lot of the stories we've heard today, a lot of the examples that he just laid out, these are margins. These are on the edges, and monitoring on the edges in our healthcare system is absolutely vital. Having more eyes, more hands is way better than fewer. And so I think that, both our providers and our insurers are trying to ensure that a patient is protected, both services and from being unduly charged. If providers really cared, they'd lower their prices. Theoretically, they wouldn't need this prior authorization. They'd come back later and fight, because that's really the relationship. You've got a payer, and you've got a provider, and you've got a patient in the middle. And the way I look at this is it's really written pretty strongly towards the providers, which I appreciate, but I went and looked on, and I've heard a bunch of conflicting data today. I heard 41 average PA requests per week, and then I heard somebody say it was by physician per week, and then somebody from Children's talked about 81,000 PA requests just from their department. And I don't mean to, if I'm misrepresenting, I don't mean to. That's just what I heard in testimony today. But when I go on to the, all this information is available. It's right online. I just happened to pull up UCare. And it basically tells. The UCare has a contract with their enrollees, and they simply state on here that some of the things that services that they're going to get have to have prior authorization. It's okay. And I think we should work on those things that that are easy, and I think we do. 98% of all services provided don't even go through prior authorization. We're talking about 2% margins, high cost, high risk, and I think that it's good to keep that in place. But as I look at the UCare thing, there was 4,600, this is in 2022, prior authorization data, 4,628. 279 were denied in medical, 3 in mental health, 1,400 in pharmacy. And, so we're talking about a minuscule number, and then the ones that ultimately get they appeal and they get back and they get approved is less than 0.5%. We're talking an infinitesimal number. So my question, Representative Bahner, I've heard twice that one of the goals of this bill is to greatly decrease the costs to hospitals, clinics. Is there an estimated? Is there a ballpark? Are we talking hundreds of millions? Are we talking tens of thousands? Is there, and maybe, Madam Chair, this question I guess is for you. If there's a cost, I know there's a fiscal note requested, if there's a cost to DHS or MDH, will this bill come back to this committee?
Representative Nadeau, yeah, absolutely.
Awesome.
It's just, this is an early bill, it's just introduced, we don't have the
Okay.
fiscal note yet.
Thank you. So that's my preamble. My specific question, and I'm only going to ask a couple. Can you tell me, starting on line 4.25, this is basically in section 6. It's about the new services that are now prohibited from prior authorizations. Can you give me a ballpark cost of what outpatient mental health treatment is and what it costs?
Representative Bahner.
Thank you, Representative Nadeau. I think I would need a friend on that. But I will tell you, I do not have that number offhand. And I know that we have actually tried to get some better data around some of these questions because I've actually been asking some similar questions to the things that you're asking or suggesting. And I know that we're trying to find out what that exact cost is. But what I can tell you is, for example, the average that you brought up earlier, where a physician is saying that they are spending, they have an average of 41 prior auth requests in a week that they're working on. It's calculating about 13 hours a week. I'm hearing from physicians that they're hiring multiple full-time staff in their clinics whose sole job is nothing but to do prior authorization approvals. They're not helping with patients. They're not doing anything else. Or you have staff who are being pulled out of the the exam room to be able to do these requests. I'm pretty sure that's not bringing down costs, candidly. We heard from a pharmacy just yesterday that has 11 independent pharmacies in the state. Not large pharmacies, necessarily, but 11. They have 30, that's 30 full-time staff whose only job is to deal with prior authorization, nothing else. 30 people. That's 3 people on average per store. And these are smaller independent pharmacies that exist all over the state, including some in greater Minnesota, right? And that says to me, if one of the aims here with prior authorization is to bring down costs overall to the system, I don't think it's working. And I think we have to be looking at costs in totality. The things on this list, and specifically in section 4, the first pieces are things like preventative care, right? By their very nature, they're intended to bring down costs. Things like generics and biosimilars, who by their very nature are designed to bring down costs. And the other items on here are very targeted. They are reasonable. They are common sense areas where there's a high level of potential harm if we delay that care. And so we certainly understand that there are many areas in which prior authorization makes sense, but it's very clear that the mission behind prior authorization is just not making it.
All right, so we do have another bill. Representative Nadeau.
Okay, I'll be quick. I had a number of questions. I won't ask them. I'm glad that you're going to keep working on this. If I can be helpful, please let me know. In its current form, I can't support it. I would love to. I can't. I mean, there's nobody that wants to drive down costs in healthcare more than I do. No one. Yeah. But I don't see the way this is drafted. How it's going to get there, and it's definitely not identified how it's going to get there. So thank you. Thank you, Madam Chair.
Thank you. And I was going to give you a final word, Representative Bahner. I think you kind of gave a good final word, but if you have a really small additional final word.
Yeah, I will say this. One of the reasons that I was so in need of doing this bill, candidly, is, as the daughter of a nurse, every day at the kitchen table, it was always about patient-centered care, every single day. And a few folks in this room know, but very few, that years ago, I actually worked for an organization, and I worked with a team of folks who was responsible for prior authorization. And I can tell you, it was really challenging to see 80-year-olds, my grandpa potentially, calling in to ask about whether they could have permission to have a cream for their toenail fungus. It was really frustrating because that could be my grandpa. And I will say, in the 20-some, almost 30 years since then, the process has not gotten better. It's actually gotten worse. And I think that when we talk about patient-centered care, we talk about streamlining and simplifying. We hear that from the businesses. We hear that from the physicians, and we hear it from the patients. So frankly, we have to do a better job, because if our goal was to reduce costs, we're failing. If our goal was to get better care, we're failing. And if our goal was to increase safety, we're failing. So there are so many places in which we have to do better, and our constituents are demanding it. So I think this bill is a good first start, and I look forward to the path to continue to have those conversations.
All right, so Representative Bahner renews her motion that House File 3578, as amended, be recommended to be re-referred to the Committee on Commerce. All in favor, please say aye. Aye. All opposed? No. The motion prevails, and the bill is on its way to Commerce. Thank you very much, Representative Bahner. You can come over here. All right, 10 minutes, see if we can do it.
All right. Members of the committee, Representative Liebling moves that House File 3443 be recommended to be re-referred to the Committee on Judiciary, Finance, and Civil Law. There is an author's amendment. And Representative Liebling, you would wish to move that A1 to put the bill in its intended form.
I would, thank you, Mr. Chair.
All right. All in favor of adoption of the A1?
Aye.
Aye. All opposed? Nobody opposes, and the motion prevails and amendment is adopted. So to your bill as amended, Representative Liebling.
All right, so members, this should be honestly a pretty simple bill for us, because this bill is really about legislative intent. So there was a very recent this is about the Minnesota Health Records Act. And let me just say, I know there are different thoughts and opinions about the Minnesota Health Records Act. It's been in effect and it's been modified over the years, and there are different, pushing and pulling among us about what it should cover, what it does cover. But what happened in October was a pretty surprising development, and that is that the Minnesota Supreme Court basically gutted it. The Minnesota Supreme Court basically said the Minnesota Health Records Act doesn't really say anything different than what HIPAA says. Now, that really doesn't make any sense, because the Minnesota Health Records Act was actually created as allowed by HIPAA to give extra protection for patient privacy in Minnesota. The very existence of this law is because we wanted to protect patient privacy in Minnesota more than the basic federal law, HIPAA. And as I said, HIPAA allows that. But in this recent opinion, which you have in your packets, Schneider versus Children's Healthcare, the court took this up and really looked at it from the point of view of legislative intent, and said in this case, and I hope you'll all take a look at it, it's not that long, and really says that when our law says, has these number of phrases in it, which you'll see in the bill, specific authorization in law, or refers to unless it's allowed by law, that we mean not only Minnesota law, but also HIPAA, which makes absolutely no sense, because if that is the case, there is no reason to have a Minnesota Health Records Act at all. So clearly, we as a legislature intended all the time that unless authorized in law means in Minnesota law, not in HIPAA itself. So what the bill does is simply restore what the court, in my opinion, broke. It doesn't deal with any of the ongoing issues that I know some of the opponents of the bill are saying, oh, here's our opportunity to start over and look at things anew. None of that is off the table. But unless we want to turn over to the courts our authority to have more patient privacy for our constituents, we need to pass this bill just to get us back to where we were and say, no, indeed, what we mean is we're trying to give more privacy to Minnesota patients. So I think this is a bill that honestly brings a lot of us together across party lines. I know that the Minnesota Health Records Act has been defended over my time here. It's been defended very strongly by members on both sides of the aisle, and we have made some tweaks to it over the years. This bill of mine does not stop us from continuing to make those tweaks. It won't solve all disagreements about how extensive this law should be. It simply says, courts, you know, you got it wrong, and we disagree with you, and we want to put it back. And I just, in the opinion, there's kind of a striking place, too, where apparently the people who brought the suit said to the court that what you're doing here basically allows anything under HIPAA to be imported into Minnesota law, and the court says this policy concern should be directed to the legislature. So here we are, we're directing it to the legislature, not them, but us. And so I would ask you to approve this and send it to judiciary.
Thank you, Representative Liebling. We do have one public testimony. Rich Neumeister, please.
Mr. Chairman, members of the committee, Representative Liebling, thank you very much for what you've done. And I say that strongly from the heart. I've been here since the late 70s. I took on the medical records issue in 84, 85, working on both Republicans and Democrats, except Nancy Bradis, who represented the Mayo area and fought hard to where patients could get access and copies of their medical records. Before that, you couldn't. As time went on, as Mr. Renner, Mr. Chair, who bears some of those debates, he's like the only lobbyist around, where we gave more protections, more control through consent, more access. 96 rolls around, HIPAA. But we knew we were with our state laws, your constituents, patients, had control. Now, this is great, and if you want more detail about what are some of the things we would lose if this would remain, you can contact me, other people. But I also want to strongly say about the bipartisanship. Mary Liz Holberg, Representative Liebling. Representative Peggy Scott, Representative Liebling. I can go as far back as Dave Bishop and Howard Orenstein, who I remember shaking hands and working out on the research thing that we is more geared for where we can control where information about us go. So, Mr. Chairman, members of the committee, I can't emphasize the importance of this bill to continue on. Then if you want to talk about all the other stuff, but let's get on the level playing field so we make sure that whatever we do, you gain some, lose some, or whatever. Thank you, Mr. Chairman, and thank you, ma'am.
Thank you for your testimony, Mr. Neumeister. I'll now ask if there's anybody else in the public that would wish to testify. Seeing none, we will move to member discussion, and I don't see any of that either. So with that, Representative, final word?
Oh, I don't have a final word except to renew my motion that House File 3443 as amended be recommended to be re-referred to the Judiciary Committee.
House File 3443 as amended will be recommended to Judiciary, Finance, and Law. All in favor?
Aye.
All opposed? No. The motion passes, and you are on your way to Judiciary, Finance, and Civil Law. Thank you.
Thank you. And
This concludes our business for the day, and we are adjourned until next Tuesday, same time. Thank you, members.